Right. Good evening, ladies and gentlemen, and welcome to this Inside St. Vincent's event. My name is Mary Lloyd, and I'm going to be your MC for this evening to share with you the achievements made possible by your generous support. And we're also going to take a look at some exciting plans for the future of heart and lung innovation at St. Vincent's. I begin by acknowledging the traditional owners of this land, the Gadigal people of the Eora Nation, and I pay my respects to their elders past, present, and emerging. And how good is it that we're here in person for one of these events? I understand that the last time that this happened was back in the time before, in 2019. So a very warm welcome to everyone who braved the beastly weather out there this evening to join us in person, and to everyone who is tucked up at home watching this online. Respect to you too. Tonight we will hear from St. Vincent's Hospital's leaders and specialists about the exciting vision for the St. Vincent's Heart-Lung Centre of Excellence. And I hope that this evening will be a special opportunity for us all to get an inside briefing on the plans at St. Vincent's Hospital and the Victor Chang Cardiac Research Institute are developing together. To start proceedings, it's my pleasure to welcome Shanthani Naidu, CEO of St. Vincent's Curran Foundation. Please welcome Shanthani.
Thank you, Mary. It's lovely to be introduced by a fellow South African. Good evening. On behalf of the St. Vincent's Curran Foundation, I would like to formally welcome you here this evening, here at the Garvan Institute of Medical Research Auditorium, and also for those of you who are joining us online. As Mary said, it's wonderful to see this small but very special crowd here tonight, just to be in physical contact with our supporters is very special, and we hope that those of you online will be able to join us at events throughout the year. Now, this is our first hybrid Inside St. Vincent's seminar, so we can apparently do things in real life and online, but we look forward to your feedback on how that goes. I wanted to also thank you all for your ongoing support over the last 3 years. As Mary said, the last even in-person Inside St. Vincent's we had was in the end of 2019, and it's been a long time, but you've all stood by us, and that means so much to us. As you know, many important developments at St. Vincent's Hospitals over the years have been enabled through philanthropy. And we're so grateful for that support, particularly to our donors, to our Heart-Lung Innovation Fund. You know that the Sisters of Charity established our hospitals, the public and private hospitals, to care for the poor and the vulnerable. And throughout the history of our hospitals, community support has been pivotal in enabling this vision to continue. Tonight, we are focusing on the long-term vision of establishing the St. Vincent's Heart-Lung Centre of Excellence. In fact, one of the very first gifts in the 1980s came from a grateful patient of Dr. Victor Chang, AC. And it was from an Indonesian businessman who was visiting Australia and was so grateful that his life was saved by Dr. Victor Chang that he made one of the first major philanthropic gifts in our lifetime anyway. And that's what inspired the establishment of the St. Vincent's Curran Foundation, or the Curran Foundation as it was then known, by Paul and Elizabeth Curran. Since then, as you know, and for over 40 years, both the Curran family and the Packer family have been incredible in their leadership and generosity in developing the philanthropy around our heart-lung programs. More recently, John and Margaret Cunningham have established the JW&M Cunningham Foundation, and their extraordinary philanthropy is making, in the last 3 years alone, is making an absolutely transformational difference to our precinct. In 2014, on the 30th anniversary of Fiona Coote's extraordinary, that first successful heart transplant, which pretty much stopped the nation for those of us that were alive then. I meet so many people who weren't that it amazes me. I have to explain who Fiona Coote was. We launched the Heart Lung Innovation Fund on the 30th anniversary of that moment. And since then, through your support, we've achieved almost $20 million for our priority projects and clinical trials. We've always been at the forefront of translational research into cardiothoracic care at St Vincent's. And most of these advances and innovations have been enhanced and enabled through philanthropy. Whether it has been the advances in the heart-lung transplant program itself, and you have to know that even through the challenges of the COVID pandemic, the heart-lung transplant team managed to increase the number of heart and lung transplants that they were achieving each year. It's quite incredible. To the mechanical circulatory support program, research program, which you'll hear from Professor Chris Haywood about tonight. We opened the St Vincent's Advanced Cardiac Imaging Centre, which was a $7.5 million project. And many of these projects, like the Advanced Cardiac Imaging Centre, have been done in collaboration with our campus partners, precinct partners, the Victor Chang Cardiac Research Institute. Also in the last few years, we've had to open we did open the first acute multidisciplinary long COVID clinic in New South Wales. And the skills of our thoracic physicians and our lung team were absolutely crucial to the success of the work that's been happening there. And Dr. David Daly will talk more on that tonight. I wanted to point out that this cross-campus collaboration, whether it's with the Garvan Institute of Medical Research or the Victor Chang Cardiac Research Institute, is at the very heart of the way that St Vincent's hospitals work across the campus. All our institutions have in common the mission and values of the Sisters of Charity, and that is unique. It is the glue that binds us together. And just as our clinicians and our doctors and nurses work across the precinct together, we are working with the Victor Chang Cardiac Research Institute on our fundraising efforts to support the vision of our extraordinary doctors, nurses, and researchers. Similarly, just as we work with our research institutes, the public and private hospitals work very closely together. And it's wonderful that we have here tonight, both online and in person, supporters of our public and private hospitals. Looking to the future, the vision of our hospitals to establish the St Vincent's Heart-Lung Centre of Excellence can only be made possible through public and private contributions, through government and philanthropic funding. Our first priority is to complete the stage 1 works within the Xavier building, and that's by expanding our intensive care unit with an additional 6 single pods and also expanding our heart-lung clinic. The support we need for that, which is around $5 million in philanthropy, is to supplement almost $25 million provided by the New South Wales government, which we are very grateful for. I will have you know that we've very pleased to say that of the $5 million target that we're aiming for, we have already achieved close to $3.5 million. So we will be looking to all our supporters to support us to get over the line on that. You'll hear a lot more about the vision and ambition of our very talented clinicians tonight. And I hope that will inspire you, as it always does us, to support them to ultimately achieve better patient outcomes for all patients, not just here at St Vincent's, but when we get things funded and we show that they're effective, it benefits all patients in Australia. So thank you again for your support, and I'll hand back to Mary.
Thank you, Shantini. We're now going to take you through a brief video which is going to explain to you some of the achievements of St Vincent's so far.
Sydney St Vincent's Hospital has led the latest breakthrough in heart transplant medicine.
A new clinic has been launched to treat patients suffering from long COVID at Sydney's St Vincent's Hospital.
Associate Professor Dr Anthony Byrne is running the post-acute clinic, and he joins us now. Anthony, thank you so much for joining us.
Sydney's heart transplant program is defying the odds, coming out of the pandemic stronger than ever.
I get to see my children again, spend time with my wife.
Head of St Vincent's Transplant Unit, Dr Paul Jans, says the pandemic has thrown many challenges.
We thought that we would have to shut the program.
Instead, they found ways around the shutdown.
You know, it's a very precious gift, and it's not something that we would lightly give away.
Instead of meeting face-to-face to follow up patients who've received life-saving heart implants, data from defibrillators, pacemakers and devices that monitor the heart can be sent wirelessly to their specialists.
When COVID hit, we realised that we had to act far more quickly, and there was a stimulus to do one of the largest rollouts of remote monitoring services in the country.
This readout shows Beverly's heart beating dangerously fast and then flatlining for several seconds. Using this transmitter, that alarming data was sent from her home in Griffith to her doctor at St Vincent's in Sydney.
A total artificial heart designed in Australia is set for human trials this year, giving hope to patients who'll require a transplant in the future.
This mechanical heart, designed in Australia, is being tested by Sydney experts.
Actually, total heart replacement. And it's actually taking the heart out, replacing it with a pump.
Initially, it will be deployed as a bridging device, but the Holy Grail is within reach.
Really what we want to have is a pump that is forgettable.
Eddie Jaku survived the Holocaust, and now the 101-year-old has also survived a heart attack.
It's highly unusual. We have never treated anyone anywhere near his age, mainly because a lot of people, once they get to that age, are very frail.
I'm doing everything I can to make this world a better place for everyone.
1968, and St Vincent's Hospital becomes the first in the country to perform a heart transplant. But it wasn't until the 1980s, after improvements in rejection treatments, that the hospital's transplant program could offer tangible hope to many Australians.
The hospital expects to perform an average of 1 heart transplant per month.
Now they're doing up to 12 transplants a month due to new technology, such as this machine pioneered at St Vincent's.
Heart failure is the biggest killer in our society.
Which is why Alan is so grateful he's been given a second chance.
Their family will never know who I am, but you know, I can assure them I'm going to make good use of the heart.
What a fantastic look at the work that goes on here at St Vincent's. I'd now like to introduce our expert panel, all of whom are directly involved with heart-lung innovation taking place here at St Vincent's. Now, some of these CVs are rather long, and I do warn you that you are at risk of wondering what you've done with your life. Professor Chris Haywood is a heart failure and transplant cardiologist and the Director of Mechanical and Circulatory Support Research Program at St Vincent's. He's also Professor of Medicine at the University of New South Wales and Adjunct Professor in the Faculty of Health at the University of Technology, Sydney. Professor Haywood's research interests include the hemodynamics of cardiac failure and advanced heart failure management. He's particularly focused on the patient pump optimization of left ventricular mechanical support devices, which we mere mortals refer to as artificial hearts. Now, unfortunately, Professor David Muller is not able to be with us this evening. He is an interventional cardiologist at St Vincent's Hospital. We did have some questions for him, but luckily Professor Haywood is able to answer some of those questions for us. Potentially, he says. Dr. Sarah Hungerford is an early career cardiologist, a Fulbright scholar, and postdoctoral researcher in Professor Muller and Professor Haywood's research groups. And I've also found out that she is a very accomplished cricketer. Dr. David Daly is a respiratory clinician at St Vincent's Hospital. He's also a PhD candidate at the University of New South Wales and is examining longitudinal monitoring after lung transplantation. He's intending to identify predictors of acute rejection, chronic lung allograft dysfunction, and graft survival. And he is co-lead on the ADAPT study, which he'll tell us about a little bit later at St Vincent's, and is exploring long COVID. The study has recently uncovered an immune profile for long COVID, potentially paving the way for tailored treatment for those with ongoing symptoms. Welcome, everyone. Let's come to you first, Chris. Heart transplants save lives, but transplantation is, of course, reliant on finding a suitable heart, and then also brings with it a range of health challenges. Can you tell us a bit about how you're working to solve some of these problems?
Sure. I think it's obvious that patients who need transplant are very unwell. Their hearts are very weak, and one of the difficulties, as you mentioned, is that we don't know how long these patients need to wait until they get the transplant. They may wait a month, but sometimes they may wait a year or 2 years. And in that time, their hearts can fail. And what we have here, and we're fortunate to have, is the mechanical heart support program. And up to about half of our patients waiting for a transplant are actually supported by a mechanical heart or artificial heart until they get their transplant. And so that's become part of our routine management and looking after these patients who really are struggling because their heart's weak, while they wait. And we want to get them in the best possible condition to get them to transplant, and so they can get through the second operation more successfully.
So what does that actually look like when a person is hooked up to an artificial heart?
It's not nearly as exciting as it sounds. The pump,
no, really, it is.
The pump is actually all internal, so that the pump sits at the tip of the heart, and it pumps continuously. So it spins. I hesitate to say like a blender, but it spins very quickly, and pumps blood continuously for the patient. And they carry around a little battery pack on their belt. Now, once they've got that on board, they can go out and do just about everything they want to do, with limitation they can't go swimming or surfing. Though we have had one of our patients in his kayak, most worryingly, also climbing the rigging on a yacht, which was also very worrying. And he was threatening to actually skydive, but I did draw the line at that, and I told him I would disown him if he did skydive. But he was an extraordinary fellow. He was very debilitated by heart failure and has now had his pump in, believe it or not, for more than 10 years. He actually was implanted when we were really working out about these pumps, before that we were committed to them just being for bridge to transplant. And we implanted him not as someone to transplant, but someone to improve their life. And he has gone on for strength to strength for more than 10 years, and he's still going at this stage.
So this technology isn't just for someone who's waiting for a heart transplant. It can be life-lengthening.
It can definitely be life-lengthening. In Australia, it's approved for treatment of advanced heart failure or severe heart failure when the heart's not pumping strongly. And across the world, about 3/4 of the pumps are implanted for that reason. But in Australia, it's only funded for bridge to transplant. And so that means just about all, Jack is our only patient who's not bridge to transplant. All the other patients are bridge to transplant patients. Occasionally we have patients who are so sick we're not even sure that they will get to the point that they're strong enough for transplant, and so we call that a bridge to candidacy, to see if we can get them stronger and then get them to transplant. But the government will fund the bridge to transplant, and we're working on them to fund the bridge to destination therapy, the long-term therapy.
Now, you've got some upcoming trials, haven't you?
Yeah.
Can you tell us a bit more
Yeah,
about
so
that?
it's very exciting. We do have a number of different pumps that we're working on. The most exciting one, which we mentioned in the video there, is a total artificial heart. The pumps I've been talking about at the moment are actually, the heart is left in situ, the pump is attached to the main pumping chamber of the heart and supports the heart. It's an assist device. What we're talking about with the new pump, it's actually total artificial heart, full commitment. You take the heart out and replace it with a machine, a device, again powered by a battery pack on the belt. Now, this was designed by an engineer from Brisbane. He's started doing some preliminary work there and then took it to America for further development and has brought it back here. And we're hoping to get it into clinical trials at the end of the year or early next year. And so we've been involved in a number of clinical studies in our transplant population. And so one of the studies we did, patients when they come to transplant, and we take out their diseased heart, we placed the artificial heart in situ, in position, just to check that it fits and where all the connections are to make sure it's all going to work appropriately. And so we've completed that part of the study, and we're looking forward to the next part, which is actually putting in a so-called live pump, if you like, a functioning pump to take over the heart completely. And that's sort of big news. It's really the artificial heart, or total artificial heart replacement, is the only organ that we completely can replace in the body. All the other organs we can support. So kidney dialysis supports the kidneys and ventilation supports the lungs. But this is really, we're talking about replacing an entire body organ. And it's very humbling, it's very scary, and it's very exciting.
And so these new ones, how are they different to what we had before, what you were using before?
So the ones before were assist devices, just the heart is left in and the pump is attached to the heart. This one, the heart is completely removed. And so all the connections that would normally go to the heart, we have to connect to the pump. So surgically, it's much more challenging. It's a much bigger operation. The patients who will likely need this kind of pump are also likely to be sicker because it's not just one side of their heart that's failing, or it's the entire heart is failing. And so it's going to be a challenge, but it is a challenge to really push us to get the best technology to help our patients.
Mm. How does the quality of life for the recipient differ from this artificial heart to transplant?
So you'll have to ask me in a year's time when we've done a few total artificial hearts. But for the assist devices, the left ventricular assist devices, the left ventricular assist devices are not quite as good as a transplant. Transplants certainly still have better functional outcomes, and you can swim with a heart transplant, which patients with these mechanical devices at the moment can't.
Yep.
I do have to say that's the next generation. That is one of the areas that we'll be researching, is how can we actually take that battery pack on the belt and incorporate it into the chest, and so then it'll be like a pacemaker, which is now very standard of care, and then patients will be able to go swimming.
Mm. Fantastic. Yeah. Sarah, I thought I'd bring you in here. Now, I understand that you've recently completed a PhD in David and Chris's research program. You've been exploring methods to better predict patient outcomes. Can you tell us what you've discovered?
Yeah, so first of all, I have to acknowledge Chris and David. They were incredible. And I did see pictures of the lab on the thing. It looked very clean there, which was nice. The key to my research is none of us are getting any younger. And with each decade of life, the risk of valvular heart disease increases. But with each decade of life, our options for how we can treat that decreases. So I'll give you an example. If you today have a severely leaking mitral valve, your chance of dying in 3 years is about 50%, and your chance of ending up back in hospital is about 90% with heart failure. So we really need to do something about it. But for most people, up until very recently, we couldn't do anything about it because doing something about it was opening the chest, putting you on bypass. And that's just not possible for many people, say, after the age of 70. So our research looked at both the mitral and aortic valve, and we used a lot of the technology through the ACIC, so very grateful for that. Briefly, the aortic valve side of thing, I've used this analogy before, and I was trying to think of an election analogy, but I couldn't, so I'll use the Tesla analogy. But so say you plug your electric car in at night, and it's charging, and you've turned it all on, it's all connected. And then you start your engine in the morning, and there's only 30% battery or 50%. At the moment, the way we're measuring energy and mechanics in the heart, we're missing a good percentage of those. So when you have your transcatheter aortic valve replacement, we are not able to accurately predict how you're going to go because we're not measuring things properly. And so our technique has been trying to put you through an MRI scanner and get all the pressures in the heart so that we fully understand where the energy or the battery power is going. So that's sort of the main focus of the research there.
And broadly, what is the significance of undertaking a PhD study like yours, for you as a clinician as well as for your patients?
Well, I actually just heard from Chris before that research is going to be incorporated into our training. So in your final year of being a specialist cardiologist in your training, you're actually going to be researching. And I think that's fundamental and potentially career-changing for a lot of clinicians. But the reality is that clinicians can answer questions that, researchers who are otherwise based in labs can't answer. And the reason we answer them and the reason we ask them is because we see these patients every day and we struggle with their management. They're coming back to our rooms with heart failure or chest pain or breathlessness. And if they can't have surgery, we need to work out what we can do. So all the techniques and skills, the same goes for a lot of what Chris is doing, is clinician-led. We're asking questions that have a material difference to the lives of our patients.
Mm. Another body of research that's making a material difference right now to people is the ADAPT study that you're part of, Dr. Daly. It was initially enabled by philanthropy in 2020. Can you talk to us about why it's so important to be able to access that sort of funding right at the onset of the pandemic?
Thanks, Mary. So, as we all know, in March 2020, we were confronted with this novel respiratory virus. There's not many times in one's career where you're studying a new disease that affects the lungs for the first time. So, we were working on the COVID ward, and we were seeing patients who were very unwell and trying to grapple with how to understand what drugs to give them, understand when vaccines may be available. But one thing we noticed was that some patients were not recovering as we would have expected after a normal virus. And so we set up this study to understand how patients recovered from COVID and what abnormal recovery looked like. Government-funded research is really challenging to attain funding, and so we're incredibly grateful for the philanthropic support that we got from the Curran Foundation to help set up this study.
So now your research that you were doing at the time, like long COVID is now well understood by doctors all over the world. Were you feeding in some of the research that you were discovering and listening to what you were hearing from colleagues overseas as well?
Absolutely. So internationally, the experience was somewhat different to Australia. The first wave in countries like Italy, United States, China, they had much greater numbers of acute infection. So we had a smaller first wave, but we still had enough patients to understand what abnormal recovery could look like. And we had the time between the first and second waves to actually do good observational research and bring patients in to St. Vincent's and talk to them about what symptoms they were complaining of, to take blood, to study their immune system, to do things like checking lung function and do heart scans. And so what we wanted to do was understand what abnormal recovery was and try to characterise it, try to describe it, give it a name, and something that we could share with colleagues overseas in terms of our experience.
And what do we now know about long COVID, and particularly how can we treat people experiencing long COVID?
So the first aim for us was really to describe what we found. And what we see is that a minority of patients, somewhere between 20 and 30% of patients in the first waves of COVID infection, had this severe and debilitating fatigue, brain fog, shortness of breath, chest tightness. They were the big persistent symptoms that seemed to last for at least 3 months after their initial infection, but in many cases have lasted 8, 12, 18 months. So we wanted to describe what we found, and then the next question was, can we predict it? Can we understand which patients might be at risk of getting long COVID? And then we wanted to ask what is different about the immune system in someone who has abnormal recovery compared to someone who is fully recovered. And so what we found was that there were high levels of inflammation in individuals who had abnormal recovery and persistent symptoms. And so we don't yet have any treatments. We think that vaccines will probably help reduce how frequently we're seeing long COVID, but we have a number of steps which we have to evolve through in terms of understanding what this new sort of inflammatory condition is, and then drug trials to understand whether anti-inflammatory medications might be able to change the course for some of these patients.
And so this was mainly because of the philanthropy that you had access to right at the start there. It's an incredible contribution.
There's no way we could have set up a cohort of this breadth and depth without philanthropic support, or to answer the sort of questions that we wanted to answer. So, yeah.
Yeah. Chris, I'll bring you back in. Now, we've heard about the vision for a new advanced translational research facility, which is in partnership with the Victor Chang. Can you elaborate on what the facility will do and what impact you think it's going to have on your research program?
Sure. So the thing about a translational facility is really connecting the clinicians with the scientists and in my area, with engineers. And so we don't let engineers into the hospital too much. You know, they're like fiddling, pushing buttons and things. So it's nice to have somewhere that we can put them. Yeah. But the translational facility is a way that we can take, clinician-based ideas, really test them test the feasibility, the suitability, the reality of those ideas, and then take it to the next level and then take it back to the hospital. And so the translational facility is really important because it does sort of bridge that gap between what happens on the ward and development of new technologies, be they pumps, be they medications or devices, valves included. And we really need somewhere that we can test whether the feasibility of the idea, the clinician's idea that Sarah mentions, the questions that we ask, is that a valid question, or is it just a pipe dream? And so that's where the translational facility fits in. It's really a key a key sort of reality check for all of our ideas to take it to the next level and then bring it back to the hospital.
Mm. And would programs and projects like the one on long COVID, would that be part of what would happen in this facility, possibly in the future?
Yeah, in the future, I think one of the things that we are looking at here at St Vincent's is not only developing, the translational facility, but also a large-scale clinical trial area. We do have the Applied Medical Research Facility here with clinical trials there, but we are always sort of pushing, looking for areas that we can, house people to run those clinical trials. As David mentioned, the trials don't sort of happen magically. They are a lot of work and require a lot of support and funding and sort of infrastructure. And so those clinical trial facilities are really key to being able to run long COVID projects. And the other thing about that we often forget with clinical trials is that they don't happen overnight, and they are long, hard work for many years. And we're now a couple of years down the track into COVID and starting to get, or as David says, starting to ask the questions that we really need to answer but to move forward.
Mm.
And it takes time and infrastructure and support to get to that point.
Yeah. Siri, you're at a slightly earlier stage in your career. How exciting is it for you to think that this kind of facility could be there in the future?
Very exciting. I think it doesn't escape me often that 10 years or so ago, we first developed a way where you could put a catheter in the leg and replace a heart valve on a beating heart. And that has saved countless lives because people, if you've had previous surgery or surgery more than once, or you're over the age of 70, we weren't previously able to fix your aortic valve disease. And we now can. And in fact, we do 7 or 8 a day. And it hasn't escaped me, today we came from fixing the mitral valve with a clip device. Now that's only just become funded. And the last case, 91-year-old, couldn't get out of hospital because of heart failure, but previously functionally independent at home. That person's going to go home and be able to return to their quality of life. And none of those techniques started without philanthropic support. So what we take for granted now is, as our current technology, was clinicians embracing clinical trials with the help of donors and philanthropic support to answer these questions and put in these heart valves. And for us, the next frontier is actually to fix the mitral valve in a few different ways, and then we've got to fix the tricuspid valve. So, we need it desperately. So,
what are those two valves?
You have the lub-dub of your heart sounds,
yep.
And the first sound is the 2 valves we really need to fix. And they make, if they fail, people are really breathless with heart failure. You end up in hospital. So, the aortic valve it's like your garden hose pipe. You can just pop it in there, and it's been working really well for us for about 10 years. But these valves are a bit more dynamic, and they're susceptible to different anatomy and fluid changes. And so we are getting better, and we are improving outcomes for people. And the work with David and Chris was some of the pioneering work with transcatheter mitral valve replacement in the world. One of the valves developed here with philanthropic support is leading, one of the leading replacement devices now. So I think that's what we do really well here. We ask questions, and we pursue ideas, and I think that for an early career cardiologist and researcher like myself, we really need to move on to the tricuspid valve and work out how we can fix that as well. And that's sort of the exciting challenge ahead.
Now, we've heard a bit about the transcatheter aortic valve implantation, TAVI. Can you tell us a bit more about that and how St Vincent's became recognised as a host site?
Yeah, so that's it's incredible technology. You you're actually awake when you have the procedure.
I don't want to know that.
You might have a little bit of sedation if you're anxious. And the catheter goes up the artery from the leg. It crosses the valve, literally blow up a balloon and deploy a valve that was crushed into a tiny catheter system. And that procedure is very safe now. You know, the risk of serious complication from that procedure is only a couple of %. And I'm talking about in people who are often very frail, who have other medical comorbidities. But that technology has become so good that it's now moved to people who are low risk. So if you're low risk for an aortic valve replacement, we are moving to the position where you should just have it without open heart surgery. So that's pretty exciting. So that's the TAVI program, which is very well entrenched here and is done really well and really safely, and as is the mitral work that we're doing. And so, yeah, I think we're just trying to... We're not trying to take away the work of the surgeons. They're very important people. But we also would prefer people not to have, you know, median stenotomies and go on to bypass because, you know, that's a big deal if, you know, if you've got a few other medical conditions.
I think the other point was it's both in the TAVI space and in the mitral valve space. St Vincent's was sort of at the cutting edge for both of those procedures. Because we were able to be supported by philanthropy through funds, so we could actually start. Because the companies who make these valves don't give them away for free, unfortunately, and so we rely on funds before they're approved by government to actually get experience, become good at it, become a leader, and ask the questions that Sarah's been answering, and form registries. To really inform and challenge the government to say, look, this is a treatment that we think works. We've got the evidence that it works, and we think you should fund it. And that's been successful. And David Muller, who can't be here tonight, has been involved very much with the TAVI program on the task force advising government, and it has been funded successfully. And similarly with the mitral valves that Sarah was mentioning, again, unfunded for many, many years, not given away for free by the companies, but we were able to get experience and become one of the largest implanters in the country through philanthropy, and then able to go to government with the evidence, with the experience and the support, and then the government has come on board and said, yes, this is a viable technology, yes, we agree it does work and we should fund it. And we're very grateful for the state government coming on board with that, and the federal government for both those valves. And so the next generation that Sarah's mentioning, the tricuspid valve, is another valve that is not funded. And we're again sort of pushing the envelope there and starting that process with the tricuspid valve. So each step of the way we're reliant on sort of outside funding first, before we can take it to the government and show that it is a valid technology and it is worthy of and appropriate to fund.
David, I was just wondering, you know, heart and lungs are obviously very closely associated. As a respiratory physician and researcher, what difference does it make to your research to have to be working on a campus like this, where you have this rich diversity of experts, and you've got your heart specialists right next door, and then we're going to have this heart and lung facility? Does that sort of supercharge the research that's available?
Absolutely. You know, our whole aim for working in the capacity we do at St Vincent's is to improve the lives of people with heart and lung problems. And so patients who have lung problems or heart problems may sometimes present with the same sorts of symptoms, like chest tightness or shortness of breath. And so it's really important to have these cross-colleague interdisciplinary discussions. You know, do we think it's the heart or the lungs, or, you know, what are the different contributing factors? So there's this sharing of ideas and consultation. And then in the research space, there are areas in which we cross over and cross-pollinate ideas. So that's I guess, the model that we're working towards.
Now, we've got a couple of questions here that are coming in from our online audience. This is a question for Chris. Do prehabilitation programs play a role in preparing patients for transplant and those that are to be implanted with a pump?
Yeah, no, I think definitely yes, we want the patients in the best possible condition for any surgery, whether it's a pump implant or for a transplant. But I particularly want to acknowledge Peter Mcdonald here. Peter's one of our senior colleagues who's been doing a lot of research in what's called frailty, which is measuring how well people will bounce back from surgery or from any insult, injury or insult. Peter's been championing the idea of prehabilitation to decrease someone's frailty before surgery. That's certainly an active area of research. But we definitely feel that prehabilitation is beneficial.
Mm-hmm. And do you think total artificial heart implantations will eventually replace the use of the assist devices? And what sort of time horizon are we thinking about here?
Okay, so I think if we can show that the total artificial heart is successful, then yes, it will replace the ventricular assist devices. But I'm going to go further, and I would hope in 10 years' time that it will actually replace the majority of heart transplants. If we have a successful organ replacement with a device, then we can get away with all the complications associated with transplantation, with all the many medications required. But that's a bit of a tall ask, and so that's where I'm really looking for and looking towards in the long term.
Yeah, that's a big statement. You heard it here first. Sarah, what other types of clinical trials would you like to prioritise with interventional cardiology if additional funding were available?
Okay, well, I think we've sort of touched on this, but there's a few other mitral replacement devices that we really would love support for, because I think, there's a few good devices that we'd really like to start testing. And the tricuspid valve, in particular, at the moment we're trialling something called a TriClip. There's a few other options, and, we'd definitely love to run some clinical trials there.
And how do patients find out about these clinical trials?
It's a good question. So probably locally at St Vincent's, there's structural heart nurse coordinators. They're probably the best port of call. So in the public, Erica O'Day, and in the private, Alexis Aragada. And I mean, they would then link, anyone in with the appropriate specialist involved in the care, but they'd be a good first port of call, and their details are readily available.
Yep. I think this information is available on the website. As Adam Van says, you can Google it.
Yes.
Question for David. Long COVID seems to have similarities to chronic fatigue. Does the research suggest that there is a relationship between the two conditions?
Clearly, there are similarities in how patients might experience these conditions in terms of this debilitating fatigue. But what we are seeing with long COVID is high levels of inflammation in the blood. And we're also seeing abnormalities in different organ systems in the body. So in the lungs, sometimes we're seeing scarring. Also in the heart, there can be scar. There can be inflammation in the brain and other organs. So these types of abnormalities you wouldn't typically see in a chronic fatigue syndrome. So similarities in the way it may present, but differences in some of the mechanisms and features.
And what impacts do you think the management of long COVID will have across a hospital and GP setting, given that the symptoms would seem to require the attention of lots of different specialists? It's a big public health cost there that we're talking about.
There is a significant public health challenge. We have huge numbers of individuals who've now contracted COVID, and a proportion of these will go on to develop long COVID. I guess the priorities are that we take patients seriously and we provide an opportunity for them to be assessed and have a full medical assessment and understand whether there's inflammation or scar in different parts of the body that may require specific treatment. and then provide a framework and an opportunity to improve their health through rehabilitation, psychologic evaluation if they need it, and of course access to novel drug trials. That's really the way through it. So I think sharing the burden across the health system, GPs, specialist clinics if required, rehabilitation facilities, psychology, and of course patient advocacy and support groups as well, I think is the right way forward.
It's becoming quite a complex medical issue, isn't it?
It is complex. Yeah.
Not that heart surgery is simple, of course. Do we have any questions from the audience here with us tonight?
May I just ask about the research in long COVID? Are you able to link in with overseas studies? I mean, is there a pooling of research going on?
I think that's a great question. So much research these days is collaborative, and these problems don't just affect patients in one particular country. And so reaching out to other academic institutions and understand what people are doing and understanding how we may be able to work together has been really important. We've had a number of different sites overseas who've reached out to us to understand what our experience has been, what questions we're trying to answer, how they might be able to help with sharing their data sets or biobanks, and then moving forward with drug trials. Clearly we need large numbers of centres and patients involved in order to prove that different drugs may work. So absolutely.
I've got one more at the back.
Professor, you mentioned just previously 10 years. You said 10 years. What do we need to do collectively to reduce that down to 5 years? Because for a bloke my age, who's had heart surgery, 57, time to me is the most crucial thing. So you say 10 years, I say, why can't it be 5 years? What do you need to make that happen? Is it monetary? Is it collaborative? Is it joining forces? In a perfect world, what do you need to turn that 10 years into 5 years?
Look, I think that's a valid question. I mean, 10 years is really just before I retire. But it is a serious question as well, because there is an urgency in the research, and resources are always one of the things. I mean, I've been very fortunate through philanthropy to set up my MCS research laboratory, and so I've been able to, in the last 5 years, make significant changes and move forward. And part of that is I'm able to support multiple researchers doing the research. I'm sort of in one position, but helping lots of people like Sarah and many other successful PhD students. And so that comes down to funding. The students no longer work for free, which is a shame. We have to pay them and feed them and that sort of thing. But so it does come down to resources, stipends for PhD students, materials. I remember when I started research, if I had an idea that I wanted to do a series of assays on my patients, I would just send off the blood form and the pathology service would do it. Nowadays, quite rightly, the pathology service will say, well, this is not routine clinical care. That should be paid for separately by research funds. And so all of those research questions have to be funded. So there are many different aspects, many different ways. It's not only personnel and equipment, infrastructure, assays, and all sorts of things that need to be funded. So it comes down to money. It does come down to money, yeah.
We've got one last question here before we wrap up. Now, St Vincent's is known as the heart hospital. How does that contribute to attracting and retaining the best clinicians? And maybe this also goes to the question of speeding up that research and getting the best minds operating.
Well, I think we are incredibly blessed here at St Vincent's. We do have great facilities. We do have a great reputation. We have involvement of many of our the alumni, the people who have worked here, but also our supporters. And so all of that goes together. And I think there is a very good feeling about St Vincent's for that reason, and that goes into reputation. What that does is it means that we do attract people from overseas, and so we routinely have an international fellow who will come to work with us for a year to get experience in our transplant program. And it is that kind of reputation and that brings people into St Vincent's. What we need to do is to continue to push the envelope, to continue to challenge ourselves and to challenge those that we're working with to really sort of think beyond the routine and what is always done. And I think that's where the excitement comes from St Vincent's, the excitement of research and the clinical challenges.
Does sound exciting. Thank you so much for fascinating discussion, and to the audience as well, and everyone at home for those great questions. I'd like to now hand you back to Shantini, who will close out proceedings.
Thank you, Mary, and thank you, Professor Haywood, Dr. Hungerford, and Dr. Daly. As I said at the beginning, I thought you would be inspired, and as you can hear from the stories that you've just heard, the philanthropy that we are so privileged to coordinate actually results in very real outcomes, be it technology and mechanical assist devices which have moved from being non-government funded to being funded, like the left ventricular assist devices, be it the mitral clips and the aortic valve implants, which you heard Sarah and Chris tell you about, which is quite extraordinary because it has gone from being novel, innovative and ungovernment funded to now being government funded, or being able to set up and help kick off important longer term research studies like the supporting the ADAPT study. With all of these things, we have done them in collaboration. So the ADAPT study, which Dr. Daly is involved with, is very much in partnership with the Kirby Institute as well. And of course, with many of our other work in the area of heart research and heart-lung research, it's in partnership with the Victor Chang Cardiac Research Institute. In terms of the minimally invasive valve trials, I really want to pay tribute to Les Shirato AM and the Shirato family, because they have been incredible supporters of the work of the interventional cardiology team under Professor Muller, and obviously with Dr. Roy's involvement as well. And if it wasn't for that their support and the support of many other donors, we wouldn't be where we are today. And I have to say, Professor Muller isn't here to speak with the passion that he would about what he calls, or he refers to as the lesser known valve, which makes me feel sorry for this valve, which is the tricuspid valve. And the only reason I can talk about valves in such great detail is because the passion of our clinicians and our clinician researchers, is what inspires us to support their work, and I hope inspires you all as well. It would be remiss of me not to say a very sincere thanks to Mary for her incredible facilitation today. We're so lucky to have such an experienced ABC journalist who's worked all around the world in many very different fields, including politics and covering foreign affairs, to help us at this level to delve into such complex information and make it meaningful for ordinary people. So thank you so much, Mary. And thank you once again for all your support. We hope you will remain connected to us and hope to see you in person or online at our next Inside St Vincent's.